In this video, I will cover one of the most common causes of a frozen shoulder clinical presentation that can be treated effectively without a medical or surgical intervention. Expect to learn why the diagnosis of frozen shoulder is incomplete, what are the main causes of frozen shoulder, how I decide if a client will respond to conservative manual therapy, and lastly, how to effectively palpate and treat the shoulder capsule. For those of you that don't know me, my name is Dr. Matt Maggio. I am a soft tissue injury treatment expert, specifically for neck, shoulder, sciatica, and hip pain. My focus is on diagnosing and treating adhesion, also known as scar tissue, and reducing inflammation from chronic injuries without the use of drugs, injections, or surgeries, which does lead to a significant increase in overall functioning, flexibility, and long lasting pain relief. I'm also the creator of the soft tissue treatment revolution, where we teach overworked massage therapists a new treatment system that will allow you to cut your treatment times by at least 50% so you can stay healthy, avoid that dreaded burnout, and help a hell of a lot more people get out of pain. All right, so let's get right into it. So, why the diagnosis of frozen shoulder is actually incomplete and not a real diagnosis? At the end of the day, we always need to have what's called a tissue specific diagnosis. We need to know exactly what the problem is, where the problem is, and how it's affecting the issue. Frozen shoulder just is a very generic term and covers a lot of things, and a lot of things kind of get thrown in there. And a lot of times when a client does have limited mobility in the shoulder, they like to call it frozen shoulder, but frozen shoulder itself is very specific and has something that we have to get to the root cause of. Because I always say, if you don't know what a problem is in the first place, you sure as hell can never expect to fix it. So, what are the main causes of a frozen shoulder clinical presentation? The first one is just going to be overuse. Over time, the muscles, the ligaments in the shoulder called the capsule, the tendons, everything around there, they get overworked and they develop this stuff called adhesion. Adhesion's like glue that gets inside the muscles in the joint, and it really makes it harder for the muscle to be able to stretch and contract how it's supposed to. And a lot of times this begins in muscles in the rotator cuff. Specifically, I see this a lot in the infraspinatus, teres minor, subscap, and the posterior capsule as well. What also occurs is some entrapments of the nerves, specifically the suprascapular nerve. I've covered that a lot in other videos, but basically the suprascapular nerve controls the supraspinatus and the infraspinatus. And a lot of times when that adhesion builds up, it causes the nerve to get stuck. When the nerve gets stuck, everything around there tightens up in a protective way to take some of the pressure off of the nerve. Because if the nervous system is compromised in any way, shape, or form, the body's not going to work correctly. So it sacrifices a lot of other things, puts more pressure on the joint, the cartilage, the tendon, the ligament, everything in there. Another issue that I end up seeing a lot is a frozen shoulder presentation comes in with a deep underlying neck problem, specifically damage to the discs and the joints in the neck. And a lot of times what happens is muscles in the shoulder become secondary stabilizers of the neck and they get really beat up as well. So it puts more pressure on the shoulder. So now the shoulder is starting to do a lot of work, not just for the shoulder, but for the neck itself. And the other one that I end up seeing is some metabolic issues, especially inflammatory issues, which are deep underlying problems that maybe it just lays down more calcification and things like that. I tend to stay away from people that have the metabolic presentation of frozen shoulder, because a lot of times even conservative manual therapy is only temporary at best because that problem continues to get worse and worse over time. So a lot of times if it looks like it's a metabolic issue, I tend to refer that out to a qualified practitioner, have them clean up the metabolic issues, and then we can go in and treat conservatively with manual therapy. So how do I decide if a client will respond to conservative manual therapy, especially to address frozen shoulder? First thing is I don't want to see a lot of history or trauma to the shoulder. That's going to tell me that there's a lot of damage in there where that tissue's just been really beat to hell and isn't going to respond as well to conservative care. And also if they don't have a lot of that metabolic condition that I talked about. Another thing I look at too is their history of how many NSAIDs they take, like non-inflammatory steroidal, whatever they're called, injections or cortisone injections as well. If a person's had multiple injections, 4 or 5 rounds of anti-inflammatories, cortisone shots and everything like that, there's going to be a lot of damage to the underlying tissue, specifically the labrum, the cartilage in the joint and the tendon. And a lot of times they won't respond as well to conservative care because there's so much degeneration in there and they're really tough to treat. Another thing is just their age. Once, someone gets up into like their 60s and 70s, a lot of times that degenerative component is so high that I don't really want to go in there and treat it that much because it's not going to respond very well. I do this functional test called the shoulder functional test, where basically we have the client start with their arm down here, and we try to see if they can bring it all the way up to touch their bicep to their ear without pain, without limitation. So in a frozen shoulder, sometimes they can't even get it up to neutral at all. What I like to see is that they can at least get it up to about 90 degrees. If they can't even get it up to there, more than likely there's like just too much damage, too much underlying problem in there, too much degeneration. Yes, we can get in there and do a conservative approach, but usually like it normally if it took me 8 to 12 visits to restore that range of motion in a perfectly healthy client, I'm probably looking at like 20 to 30 visits. And a lot of times clients don't want to commit to that process. They don't want to stick through with it. They don't see it all the way through the end. You can help them, but it's not going to be a slam dunk case. Now, what I want to teach you in this week's video is how to effectively palpate and treat a main culprit of frozen shoulder, which is actually the posterior shoulder capsule. So what I'm going to link up first is a detailed demonstration of me palpating that area, then treating it, and you can see how we break down that adhesion and scar tissue and restore range of motion and flexibility back to the joint. So I'll link that video up right now. So in order to find the capsule, it lives back through here. And where it lives is between the tricep and between the posterior delt. So what happens is people usually end up being too far posterior on the tricep. See how that doesn't feel good? Or they're too much on the rear delt. So what I like to do is I like to use some landmarks. So I'll hold it right here to kind of palpate it. And then I like to open it up a little bit with some of that flexion. And then what I do is I'll go in here and find the humerus. So I'm like humerus, tricep, humerus, tricep, humerus, humerus, and I'm just going through and trying to figure out, because this is when I start hitting into the delt a little bit and I can roll it over here, here, and then where that capsule comes in is right there. Is it tender, Jess?
The compression is tender.
And the capsule is going to be tender because it's a ligament and you have to get on it. Now the difference between the capsule versus any other treatment on here is we actually don't back off once we get depth. We ought to keep it. It's still internal slide, but when we go in there, we're going to go straight in with our depth. So I go straight down here, but I don't come out for my tension and from my depth. And then my tension is right into it like that.
So you're heading towards the lateral aspect of the.
I'm just going right into, right up into the capsule, and it's a very short movement. And you'll feel where that humerus comes. And it's going to be a little tender. And then basically what I do is I get my depth in, and then I get my tension, and then my motion is going to be to bring it back just like that. And see how that builds up, Jess? Here we go. Here, and I'm just bringing that arm back towards me. And it's going to be very tender. And then I drop it in just like that. And then with the capsule, what I do is I lean and I hold it for about 10 seconds because it's deep. You okay?
I only felt it in the beginning.
Yeah, and that's what you'll feel is that first, it's just sensitive because a lot of people, especially when she has limited range, it's going to be inflamed in there. So the key is this breaks all the rules. Like normally it's depth, come out, then tension. She goes right in there and opens that up. So as you're getting used to the motion, it's hard. Remember what we always said, I hate having my thumb out in space when it's not protected. Normally what I want to do is, and if it's bad for the client, they got to move it for you. And I mean, you got to move it for them. Ideally, I'd like the client to do the motion for me, where she's going to bring it straight back just like this. And what I like to do is just try to get that. So I'm going to show you what it looks like here. So just hold that there. And then, like I said, tricep, delt, tricep, delt. Now what I can do is now I can really get in there with both hands backed up. And now I can get a lot more. So my depth is with my body, and my tension's here. And go ahead. And then what I can do is I can use my hands to bring that back just like that. And now I can really lean in. And that really helps me generate a lot more tension. So just a couple of take homes from that treatment demonstration. Number one is just use landmarks. You know, I find things that are really big and can help you in the palpation. You know, we're separating out the posterior delt and the tricep and finding that humerus and getting in there and then finding exactly where that capsule lives. Because I always say if you can't find it, you can't fix it. Next thing is just going slow And being precise. So much of manual therapies out there is what I call shotgun approach, where they just kind of do a bunch of stuff and just see what happens. They treat a million things in one visit. They don't really know what's working. I want to teach you more of a sniper approach, where you dial in, you find it, you get it, and you treat the thing that needs to be treated the most, so it's effective, safe, and durable. Next thing you saw in that treatment, it's different. Normally, when I'm treating a muscle or a nerve entrapment, I get some depth into it and then I back out a bit and then I set some tension. When I'm treating the capsule, since it's a ligament, it's really balled up and really deep in there, I actually get my depth and I don't back out and then set my tension. That's going to hold more pressure and break that down. We almost want to hold it at that end range for anywhere from like 10 to 15 seconds. That's going to put you in a really good place. Next thing that I always do, and I always teach in my treatments and my system, is testing to see where it's at, then treating it, and then retesting it. And we should see some type of improvement. We should also see that it held over a few days or a few weeks. That helps us understand that the treatment is durable. There's three components to a treatment. It must be safe, effective, and durable. Most treatments out there are safe. Some are effective because they do temporarily feel better, but durable is where it can actually be long lasting and you make a physical change in the material, in the tissue, in the body, and breaking that down and putting it in a good place. Because honestly, if you're not getting durable treatments, you're not actually doing treatment. You might be doing some maintenance or recovery, and that's totally fine, but you're not getting to the root cause of fixing and solving the problem. Thanks so much for watching the video. And if you're struggling to figure out exactly what is going on with your client's injury presentation, you feel like you're stuck guessing and always on a path to try to learn some new type of advanced technique, only to be stuck in the same loop of what I call winging it and trying more stuff, then go download our free training modules that help change the way you critically think about figuring out the issue and treating in a new way that gets long lasting results, and get on the path to being a true problem solver. Links to that can be found in the description or wherever you're consuming this video. I appreciate you watching, and we'll see you on the next one. Bye.